This morning we're talking about immunologic disorders of the kidney, in particular glomerulonephropathy or glomerulopathies. This is on page 1073 or 1131. I think that's right in your book. Oh, I don't know why I'm holding my phone. Okay. Okay, everybody have this PowerPoint and handouts. Should. You didn't do anything all weekend, so you should be prepared, right? Did you read this? Anybody? Damien, you did. Okay. Destiny, you did. Anybody else? 2 people out of 53. Not a good record. Okay. All right. So, table 46.8 in your book is an important one we're going to talk about in just a second. On the first slide, it says that disorders of glomerular function, primary glomerular disease, also referred to as glomerulopathies, causing destruction of the glomerulus of the kidney. How important is your glomerulus? Okay, how do I know your patient's in renal failure? The GFR is what, Katrina? Okay, well 15, I'm in end-stage renal disease, right? Okay, so what is normal GFR? 125 to 130. So if I go below 100, am I in trouble? So my kidneys have what? Suffered a hit. There's been an event, okay? What are the main causes of renal failure? Acute kidney injury? Hypotension? Diabetes, hypertension, hemorrhage, okay? So what are the 3 categories of the types of renal failure?
This is a test. This is a test of the Orangeburg calf.
I think we do this enough, don't y'all think? They need to change times or something. Change times besides it being 8 o'clock on Monday mornings. Pre, intra, and post-renal. And everybody remembers the mechanisms of those. Okay, very good. This is the 3rd most common cause of stage 5 chronic kidney disease.
This is a test and only a test. In the event of a real emergency, you would have been provided emergency information and instructions. This is only a test.
Okay, everybody knows where you're supposed to go if we have to evacuate this building. You go down there by that building down there, whatever it is, T or P or something. Okay, you go to the end of, and if this building exploded, are we far enough away? No, but anyway, it doesn't matter. That's where we're supposed to gather. Okay, and I would need to take roll, so I need for you to all be there. You don't get to take your pocketbook or anything else. You leave it all here. That's why, another reason why these doors are locked. So if we have to exit this room, the doors are locked, right? Okay, so one day we had a bomb threat. Miss Blackwell and Miss Goff and I were all leaving, and Miss Goff turned around, and Miss Blackwell fell, and Miss Goff said, "Oh, I have to go back and get my purse." There were Miss Blackwell and I. She had fallen. She had an injured knee, and we were standing out in the front out there. So if something had happened, exploding out there, we were standing out near 601, we would have been dead. But anyway, it was ridiculous. So we would keep you as safe as we can. How about that? Okay, so these glomerulopathies are the most common cause of stage 5 chronic kidney disease. Okay, stage 5 is what? End-stage renal disease. Glomerular capillaries are the site of involvement. This is a process of inflammation of the glomeruli. There is no infection in your kidney. I need for you to have that perfectly straight. There's an inflammatory process going on inside the renal parenchyma, in particular affecting the glomeruli. This is not a mechanism of infection in your kidney. Everybody clear on that? It's only inflammation. Oh, it can be divided into primary and secondary. It affects both kidneys equally, so it is bilateral. It's groups of disorders, and what categorizes all of this is that they have similar manifestations, okay, clinical manifestations. Okay, what is an antigen-antibody complex? What is an antigen? A what? Like a bug? Like what, David? An anti-antibody. What does that mean? You're correct. What does that mean? Anybody? Okay, it's like the anti-antibody is fighting myself, right? Okay, so what disorders cause that? What does that happen? What disorders happen in that? Ms. Blackwell talked about them. Autoimmune disorders. Very good. Okay. So when I think about an antigen, Caitlin, what's going on with you this morning? She's got allergies going on. So what's an antigen? What's an antigen? Anything that you inhale, ingest, is injected into you that's foreign to your body, that is a non-self cell. Okay? So is pollen a non-self cell? Does your body react and respond to those non-self cells when they get inside of you? So how many of you have a propensity for strep throat? That means you get it. You get strep throat. How many of you get strep throat? Actually, 3 or 4 or 5 of you. Okay, very good. So what do you do when you get that sore throat? Do you go to the doctor immediately? Why not? Yeah, I know, but do you know that if you let that strep infection continue, that you can have long-term complications? So we're going to talk about those. So first thing you should do is go get it checked. Do a quick strep test. Okay? Yes, I know it's costly, but it's more costly if you have cardiac involvement or renal failure. Okay. So when that foreign substance gets inside your body, those immunocompetent cells, so we're doing a little immune here, okay? So those immunocompetent cells react to that foreign invader, okay? So those immunocompetent cells, what cells form antibodies? Nope. B cells. Why? B cells, antibody has a B in it. Okay, antibody has a B in it, so B cells. B cells form antibodies. B cells, when they become sensitized, are antibody-producing machines. They produce thousands and thousands and thousands of antibodies to protect you. Okay, this is on the first encounter of that foreign substance. Then when you have a secondary exposure, they attach to that antigen immediately. And so when they attach to that antigen, because they're an immunocompetent cell, they say, hello, everybody out there that can help us gobble up this invader. We need you to come to this site. So what is something that comes there that enhances the response of that antibody? Starts with a C. Complement. Thank you, John L. Complement. Complement comes and it coats the antigen-antibody complex, and it causes in other, let's see, what cells was it that you wanted to tell me last week that were the white blood cells that were phagocytic? Did you not say them? Big macrophages. Okay, they call macrophages in. They're like Pac-Man. They gobble up to take care of this foreign invader. Okay? Now, wherever that antigen-antibody complex is, plus the complement, it can cause tissue destruction. Everybody following what I'm saying here? Okay, so wherever those antigen antibodies come in, it can cause tissue destruction. So if it came into your nose, what happens to you in response to that antigen antibody complex and complement going on in there? What do you have? Sneezing, runny nose. Is it clear or colored? Mucus. Clear? Okay. So that's called what? What's the word for that? R. Rhinitis. Rhinitis, okay, when you have a runny nose. So there's tissue inflammation in that area. So what happens with these glomerulopathies is that there is an infection in your body. There's an infection in your body, not in your kidneys. The infection causes that antigen-antibody complex to be formed. And what happens when they're formed, they get stuck in your glomerulus because they're in your bloodstream, aren't they? Okay, so you remember IgG, IgM, IgA, IgE, all of those Igs? Okay, those are antibodies. So what happens is that those antibodies and antigen complexes get stuck in your glomerulus, and they cause an inflammatory response, and they cause destruction to the basement cell membrane. Everybody remember what that is? Okay, they cause destruction of the basement cell membrane. So if we complement antigen-antibody complexes plus complement causes destruction of that basement cell membrane. Now, it causes holes in that basement cell membrane. What do you think are constituents that are going to go across that basement cell membrane that probably shouldn't be going across because it should be only microscopic things going across, right? So what's going across in my urine? Red blood cells, white blood cells, platelets, and protein. Very good. So what is happening is that because there are holes in this basement membrane, I'm going to have increased amounts of protein filtering across or going through those holes. Okay? Also, because there's actual damage to the cell membrane, there's going to be frank bleeding, frank blood, red blood cells in your urine. What color is your urine when there's blood in it? Coffee colored, tea colored, cola colored, anything that's not normal, rust colored. Okay, it depends on the amount. Now, I've talked to you about the fact that sometimes you can have microscopic means what? I can't see it with my naked eye. But if I see rust-colored urine, some kind of bleeding is going on in that glomerulus. Okay, the glomerulus has been damaged, and there is bleeding actually from those structures into the urine. So I'm going to have red blood cells and red blood cell casts associated with the diagnosis of glomerulonephritis. So red blood cells, red blood cell casts indicate the damage to the glomerulus. Protein. Three main things you're going to see in that urine. Okay, does everyone understand the antigen-antibody complex formation plus complement? Answer on your test. Okay, so the second bullet says the inflammatory response is in the tissue of the glomerulus. Major clinical manifestations of glomerular injury include, what's the first one? Proteinuria. The second one, hematuria. The third one, decreased GFR. And how would I see that reflected in my patient? Decreased urinary output. And what are the two terms for that? Anuria and oliguria. Or oliguria first and then anuria. Okay? Decreased excretion of sodium. Edema. Now, I talked to you about renal edema. Where's the first place it's going to come? Periorbital and then peripheral. Okay, no, I'm not going to be the Michelin man yet. Okay, and hypertension. Maybe. We're going to talk more about these. All right. Secondary glomerular disease is associated with systemic diseases like you told me earlier, diabetes mellitus. Can that lead to renal failure? Systemic lupus erythematosus. Can that lead to renal failure? Okay, multiple myeloma. Who knows what that is? Y'all just had hematology. Yeah, it is. What kind of cancer? Where is it? Bone. Hereditary disorders. We'll talk about that in a second. Response to allergens and toxins. Does that stimulate an immune response in your body? So any immune response in your body can lead you to develop glomerulonephritis. Cocaine use can also, it's just not good for you. It's not good for any of your systems in your body. If you anybody allergic to bee stings? Angie, you carry an EpiPen? Where are bees? Everywhere. I love that movie. Was it Tammy where he was trying to arrest her? Bees. Anyway, never mind. Moving along. Okay, it says glomerular injury is only part of the overall process. I'm going to tell you it can be an acute state or a chronic state, and we'll talk about that. Acute is more often occurs, and acute versus chronic means what? What do I know about acute? Sudden, okay. Hopefully, if it is that acute state, then it is only temporary and it is reversible, that your patient can heal. Now, is there going to be some degree of scarring probably in the glomeruli if they're destroyed? Okay, good. Chronic is a slowly progressive disease. What is that? Somebody's recorder. Oh, that's you, Christine? Is your battery dead? Okay. Okay, if it's chronic, can we fix it? No. Okay, all right. Now, this is where the hard part comes in. It says glomerulopathies may be categorized as either nephritic or nephrotic. One has two I's and one has an O. The one that has the O is the one that I need for you to relate to the Stay Puft Marshmallow Man or the Michelin Man. Okay, O, you're round and you're big puffed up. Okay, some glomerular diseases, however, can manifest with features of both. So I can say to you, you might start out in a state of nephritis that you develop nephrotic syndrome. Okay, so nephrotic syndrome is worse than nephritis or nephritic syndrome. Yep. Okay, it says all types of glomerulopathies have three common factors. Number one, the basic problem is what? An allergic reaction or an immunologic reaction that affects the glomeruli. What did I tell you happens in there? The antigen antibody gets stuck down there, and what else enhances that immune response? Complement, okay? So that causes what in the glomerulus? Inflammation. What other two tests do I need to look at as far as inflammation is concerned? C-reactive protein and ESR. Very good. It says, number two, that the glomerular basement membrane is abnormal. Protein leaks through the glomerulus and appears in the urine, producing variable degrees of proteinuria. So I can have mild to massive protein loss. Mild protein loss to massive protein loss. So which one do you think is going to have mild protein loss? Nephritic versus nephrotic is going to have massive protein loss. And this is constant. Then number three is inflammation leads to microscopic or gross hematuria. So which one has microscopic hematuria, you think? Nephritic. Versus what is, hang on, let's take that back a second. Actually, nephrotic has microscopic hematuria, but nephritic has gross bloody urine. So nephritic syndrome, I have lots of damage to the glomeruli, lots of bloody urine. Okay, gross hematuria. Okay, so it says glomerulonephritis begins with formation of antibodies directed against the invasion of the body by foreign organisms or proteins. I just went through that, right? Everybody understands antigen-antibody complex? It can also be an autoimmune response. We already talked about that. That is directed toward destruction of the glomerular basement membrane. Don't know why this occurs. So the next bullet says that antigen and antibodies form a protein complex that becomes trapped in the glomerulus and interferes with glomerular function. But wherever that antigen antibody complex is, what enhances that response? Complement. Okay, the next bullet says the kidney becomes swollen and pale. Is your patient going to be experiencing any symptoms associated with a swollen kidney? What? Pain. Okay, good. Then the last bullet says the damaged glomeruli allow protein and red blood cells to enter the filtrate. Now, if there's destruction of the glomerulus is going to bleed, and so what goes along with those red blood cells in that urine? Red blood cell casts. Red blood cell casts indicate to me direct destruction of the glomerulus. I see some of you not writing this stuff down. This is important. This indicates direct damage to the glomerulus. So if there are red blood cells and red blood cell casts, there's direct destruction to the glomerulus that causes bloody urine. Okay, all forms of glomerulopathies are characterized by antigen-antibody complexes plus complement. That's going to be on your test. Resulting in tissue injury, that equals glomerular injury. So, is history going to be very important in this patient? Okay, so if they've been exposed to certain drugs, or if they've recently received an immunization or had an infection in the last, what, 5 to 21 days, that could be significant. It could be bacterial or viral. It could be hepatitis B or C as well. So if your patients just experience that, they can experience glomerulonephropathies. So immune disorders such as systemic lupus erythematosus, scleroderma, and diabetes. Strep is a bacteria, right? Okay, so do you see how important it is for you to get that strep throat treated? So right now we have a decreased number of individuals who have renal failure because of group A, beta hemolytic strep, because it's no longer destroying the kidneys because you're getting it treated. Does that make sense to you? How long is it okay for you to go without getting that sore throat treated? It's not a good idea. You need to go immediately. Those of you who already know that you have a history of strep. Okay? Questions so far? It's not so bad yet, right? Okay, good. All right. Acute post-streptococcal glomerulonephritis is one type of glomerulonephritis. This is not the only type, right? We've talked about several causes. And let's do that right now. Go to table 46.8 in your book. So these are causes or risk factors for glomerulopathies or glomerulonephritis. And I told you that glomerulonephritis can either become nephritic syndrome or nephrotic syndrome. Okay, so on the left-hand side, cause or risk factors, infections. These are primary causes of glomerulopathies. So the first one is post-streptococcal glomerulonephritis. It may develop 1 to 2 weeks after a streptococcal throat infection or rarely a skin infection such as impetigo. Do you need to get your sore throat treated? Antibodies to strep antigen develop, and the antigen antibody deposit in the glomeruli, causing inflammation. And what also comes along there to enhance all of that? Complement. So add complement. So put plus sign complement there. Infective endocarditis. What is that? Who talked about that? Ms. Blackwell talked about cardiac. What is infective endocarditis? What? Yeah, it affects your heart. That was good. What else? What causes it? Strep. Okay. Number one. Okay. So if you have, when she talked about cardiomyopathy associated with strep, what does it affect? What is the strep antigen antibody attached to? Which one? Mitral valve. And it can cause what? Prolapse? Mitral valve prolapse, okay? Okay, so can you live a lifetime with that? What's going to eventually have to happen? Yeah, you're going to have valve replacement, okay? So if you treat that sore throat, you've prevented that endocarditis, right? Okay, so patients who have had any type of mechanical device in their heart, what is something that they need to do before they have any invasive procedure? What antibiotic? Whatever the doctor prescribes? Do they need to know that you have a history of that? Do you need to wear a medical alert bracelet that tells me that you have an artificial heart valve? That you have stents in your heart? That you've had a bypass surgery? That you have, we haven't talked about congenital anomalies, but there's certain, like we can do a balloon angioplasty. If you have a hole in your heart between the two atria, and we can put in like a little umbrella like valve that closes, so that which side of the heart has highest pressure, left or right? Left. Why? It's getting it out. Okay. So if I have a hole in infancy, that's called the foramen ovale. I know you remember that term from anatomy, right? That hole between the two atria in the infant, in the fetus. And so what happens is that it can stop. It cannot close when it's supposed to close, and there are identified parameters within how many weeks. And so if there's a turbulence of blood in there, what would the doctor hear as far as that patient is concerned listening? A murmur, okay. And so do we need to do something about that? Sorry, my nose is running too. So I have to close that hole, okay? That's a little tiny do nothing. They can do a cardiac cath, put that little umbrella in there, open the umbrella, and it just, because of the heart pressure on the right side, it keeps it closed. Now, as I grow, is that going to have to be replaced? Yeah, because it can leak, okay? So if I have any of those things inside of me that are foreign to my body, then I have a history of strep throat and a history of, I want to prevent bacterial endocarditis. So what is this prophylaxis that you call that you're going to give me to give that antibiotic? What am I trying to prevent? Yeah, but what's it called? How about SBE prophylaxis? Anybody remember that? Yeah, Miss Blackwell talked about it. I know she did. Didn't she? Subacute bacterial endocarditis? So before you go get your teeth cleaned, before anybody do that? Nobody? Okay. All right. We'll talk more about that. That's not on this test, to be determined later. But you know what? Everything has to work together, doesn't it? And so this affecting your heart also affects your kidneys if you have strep. So don't wait. Okay. Where am I? Bacteria can cause an infection one or more of the heart valves. Which one I tell you? Mitral valve. People who are at risk include those with a heart defect, such as damaged or artificial heart valve. Bacterial endocarditis is associated with glomerulonephritis, but the exact cause is not known. Bacterial endocarditis. All right, viral infections can trigger glomerulonephritis. Common viruses include HIV. I didn't talk about that one, did I? Hepatitis B and C. So viruses. Then immune diseases are secondary causes of glomerulonephritis. So all of those at the top are primary causes. Secondary is immune disease. Systemic lupus erythematosus, you know it's an autoimmune. Have you talked about this yet? We'll talk about it in the fall. Scleroderma, have you talked about that? Goodpasture syndrome. We're going to talk more about this. So what it says it is an autoimmune disorder causing lung and kidney disease. Wherever there is basement membrane, that's Goodpasture syndrome. Lungs and kidneys can cause you to die because there's bleeding into the lungs and into the kidneys. Okay. Other risk factors or causes, IgA nephropathy. This is another primary cause of glomerulonephritis. It says it results from deposits of immunoglobulin IgA in the glomerula, characterized by recurrent episodes of hematuria. Then vasculitis, which includes polyarteritis, Wegener's granulomatosis. These are secondary autoimmune diseases affecting blood vessels. This summer you'll talk about Kawasaki disease. Anybody ever heard of that? Yeah? Okay. So you'll talk about Kawasaki disease. It causes polyarteritis. So an inflammatory response of all your blood vessels in your body, and your skin sloughs off. Conditions that cause scarring of the glomeruli. This is a secondary cause. Diabetic nephropathy. Important for you to remember. Primary cause of end-stage kidney disease. Microvascular changes of diffuse glomerulosclerosis involving thickening of the glomerular basement membrane. Can we reverse that? No. So what did I tell you about diabetes? Can we prevent diabetic nephropathy from happening? No. You can't prevent it. It is eventually going to occur. You can only postpone how quickly it occurs. Does that make sense to you? So everybody who has diabetes is going to develop all of these changes associated with diabetes. It's just a matter of time. And so the more closely you can maintain your blood glucose levels within those normal parameters, the longer you can postpone the complications. Hypertension. Hello. Number 1 and number 2 reasons patients are on dialysis. Nephrosclerosis is a complication of hypertension. Can also glomerulonephritis can also cause hypertension. Okay, well, great. Focal segmental glomerulosclerosis. I don't care that you know that one. Amyloidosis and illegal drug use. Hello, what is that? Cocaine and heroin? I don't know what. What's the other thing you grind up the Sudafed for? Methamphetamines. Does that cause you to have glomerulonephritis? I know you lose all your teeth. You have this funny looking color to you. Y'all know what I'm talking about? Hello? You can look at them and you know. Okay. These are causes, okay? All right. So the first one we're going to talk about now is acute post-streptococcal glomerulonephritis. Again, this is just a cause. More common in children and young adults, but all ages can be affected. It follows a 5 to 21 day after an infection, sometimes referred to as an antecedent infection. What does antecedent mean? Before. It precedes. Okay? So I'm sick today. So what happened to me in the last week or 2 weeks? Oh, I had an upper respiratory tract infection. I had an allergic reaction. My allergies were killing me. Okay? So it says, an infection of the tonsils, pharynx, pharyngitis, or skin by nephrotoxic groups of group A beta hemolytic strep. Does that need to be documented? Maybe. How else can we tell if you have a strep infection? You're going to draw my blood, and what are you going to look at? Okay, an ASO titer on your test. ASO titer. Anti-streptolysin O titer. ASO titer. Anti-streptolysin, anti-streptolysin titer. So if the ASO titer is elevated or high, do you still have an infection? Yes, then you need to receive an antibiotic to stop the formation of antigen-antibody complexes, to stop this glomerulonephritis. Did you follow what I just said? What did I just say? If there is still an active strep infection going on, then your patient needs to get an antibiotic to treat the strep. Now, 21 days later, it might or might not still be elevated to the point that it indicates I'm infected, but yet it still indicates that I have had an infection with this group A beta hemolytic strep. Correct? Okay, everybody with me? It says tissue injury occurs because the antigen antibodies complexes deposited in the glomeruli where complement is activated, causing what? An inflammatory response. Is there infection in your kidney? No, there is no infection in your kidney, only inflammation. History and physical, is that important like I've said to you before? Okay. Questions? Everybody good so far? Okay, good. Clinical findings. May be mild to asymptomatic, or the patient may present with oliguria. How do you know if you have oliguria? You're not measuring your urine. How do you know? You're not normal. You're not going. Do you know how many times a day you've been in that bathroom? How do you remember? Sometimes I'll leave here and only been once. Sometimes I'll leave here and only been twice. Am I drinking enough fluid? No, you aren't either. May also be experiencing anuria. So oliguria, what's the definition? Less than 30 milliliters an hour, but less than how many in 24? 100 to 400. Okay, and anuria is less than 124. Clinical onset is usually abrupt. Proteinuria is mild. Proteinuria is mild. What is in red? Gross hematuria, smoky, cola, reddish-brown, tea-colored urine. This indicates damage to the glomerulus along with red blood cell and red blood cell casts and oliguria. Indicates damage to my kidney, to the glomerulus. Is there infection in my kidney? Only inflammation. Circulatory changes are associated with sodium and fluid alterations. What do you think my patient's going to present with? So I have oliguria and bloody urine, and what else? Is this going to be probably persistent bloody urine, or it's going to kind of come and go? Persistent. Okay, so what else am I going to have? What other symptom am I going to have associated with this that you can assess? Hypertension and edema. Very good. Okay, hypertension and edema. So make sure that you remember that. Okay, this little man is on shared files. This is glomerulonephritis. So up at the top here, it says what? This is glomerulonephritis associated with group A beta hemolytic strep. Okay? So antigen antibody complex from recent strep infection, forms. What goes along with that? Complement. That gets stuck in my kidneys. So it says antigen antibody complex and glomeruli cause inflammation, decreased glomerular filtration rate, and how am I going to see that in the urine? Oliguria. Well, let's just go Ollie first, okay? Okay. All right, and because of that, I have decreased filtration of the kidneys because my GFR is decreased. I have headache. What caused the headache? What? Blood pressure. And edema. Okay. I have elevated blood pressure. I have facial or periorbital edema. Something wrong with my kidneys. I have malaise. What are some other things I could be experiencing? I'm just so tired all the time. I don't know why my urine is this color. It's been this way for about a week. Hello. It's not going away. Low-grade fever. Weight gain from what? Edema. Good. And in my urine, there's going to be protein and blood and decreased amounts oliguria. This is a very good little slide for y'all to have a handout of. Okay, questions? This is acute post-streptococcal glomerulonephritis. Okay, my patient can experience mild to moderate hypertension with no retinal alterations. What does that mean? So my eye grounds are okay, my retina looks okay, it's undistorted. Edema of the face, periorbital, and hands, peripheral, and ankles, feet. Yes. Okay, now, if I have dyspnea and orthopnea and a cough, what does that indicate to you if I have fluid overload? Pulmonary edema or congestive heart failure? Good. What are you going to hear? Okay, some kind of adventitious sounds, right? I got pulmonary edema going on. Might have a pleural effusion, a positive hepatojugular reflex. What does that indicate? Fluid overload. Ascites, where's that? Okay, now, as my condition worsens, this is what's happening to me, okay? Cardiomegaly, a gallop, heart rhythm, S3 heart sounds, fatigue, lack of energy, malaise. It talks about nausea, vomiting. Oh, it says if uremia from renal failure is present. Can glomerulonephritis lead to renal failure? Bless you. Now, which category of renal failure would this be? What'd you say, Laura? Intrarenal. Why? It's affecting the glomeruli, right? Okay. So glomerulonephritis is a mechanism of intrarenal renal failure. Can lead to. Can you understand how that's happened? We got oliguria, we got decreased filtration. So what else is going to be elevated in my patient that I need to look for? That could be also contributing to these heart sounds. Potassium. Okay. All right, good. I've got a pale, what kind of kidney? Okay, why wouldn't that pain just send you to the doctor? Because we're so bad about just living with it, right? No, we'll go to the doctor and he'll give us Lortabs. "95% of patients who have acute glomerulonephritis have full recovery. However, what happens to the other 5%? Chronic glomerulonephritis and chronic or end-stage renal disease. Okay, questions? Okay. So the next slide talks about managing this. So, what is the number one thing we need to do to prevent this? If you have a sore throat, go to the doctor, okay? Especially if you already know you have strep. So prompt treatment of all infections. So treat your sore throat. You need to be monitored for your ASO titers. Want to make sure that they're decreasing. Need to give an antibiotic to treat that strep. And when you give somebody an antibiotic, you must instruct them what? Take it all as prescribed until it is gone. Even if you forget one, can you take it later? Yeah, you're going to be off your schedule just a little bit, but you need to stress to them the importance of making sure that they take their medicine. Encourage patients with a history of acute post-streptococcal glomerulonephritis. Seek medical attention at the earliest onset of strep throat. Should have yearly exams. Do y'all? Nope, I know. Good personal hygiene, bless you, to prevent the spread of streptococcal infection to the skin. Where is strep? Yeah, it is. It's everywhere. Just certain people are more susceptible to it. So I'm going to talk to you about another type of strep that you could be a carrier for. You could be harboring strep in your vagina if you're female. That can cause problems during pregnancy. So if you're a carrier of strep, then they will do a culture on you to make sure that you don't need to be treated. Okay, so that would be prior to delivery. You would get antibiotics. Baby maybe get some antibiotics after it's born. So a bad story that had a patient probably 30 years or more ago, and she had this beautiful baby boy, and all of a sudden he started having some difficulty breathing, and skin started mottling. This is in the delivery room, and I told the obstetrician I was taking him to the nursery. That baby died within an hour. Died within an hour. He was over 8 pounds, almost 9-pound baby, beautiful, perfect baby, and he was dead. And it was group A hemolytic strep that she was carrying in her vagina. So now you will have a smear, a culture to make sure that you're not a carrier. And if you are, then we can treat you. But it's best to know ahead of time not to jeopardize that baby that you've carried for 9 months. Okay. So strep is everywhere. That's just another example of where it is. Antibiotics, again, if you're prescribed antibiotics for that strep infection, take them until they're gone. Don't save some for the next time you get a sore throat. You're not going to have enough. And that's when you create those superbugs. So follow-up is very, very important. As long as your patient has hypertension and edema, what do we need to monitor, and what should we do as far as their intake? Okay, daily weights, blood pressure, I&O. Is there anything else? Yeah, but diet. Decrease sodium and monitor their fluid intake. Okay, so what could we revert back to as far as their fluid intake? 500 to 600 milliliters plus output. Okay, very good. Good. What else, if my kidneys are compromised, do I need to be careful about this patient consuming? Protein. Okay, protein. Because I already talked about, or 2 grams, 2 to 3 grams. So I already talked about the fact that we need to monitor for hyperkalemia, right? Okay. Okay. Diagnostic studies. So the diagnosis is based on the history and physical of this patient to identify that Group A beta hemolytic streptococcal glomerulonephritis. So I'm going to look at their serum creatinine and BUN. What's going to happen to the serum creatinine if I have compromised renal function? Okay. Hemoglobin and hematocrit. Now, if I got that much blood going out of me in my urine, what's going to happen to my hemoglobin and hematocrit? It could be reflected in that. Okay. So it says that may reveal mild anemia. What else is a contributing factor? Bless you. Y'all are sure sneezing a lot. I think it's the pollen. They say it's the highest count today of ever so far this spring. Okay, what was I asking you? What else is going on with this kidney that's sick? Why would I have anemia? Decreased erythropoietin production. Okay. So I need to look at a CBC with the differential. Okay, good. Next bullet says variable increases in serum sodium and potassium. As renal function deteriorates, what's going to happen to potassium and sodium? Hyperkalemia and dilutional hyponatremia. Because I'm retaining fluid? Yes, because I'm in a state of oliguria. I got a headache and I have edema. Are you making the connection? All of these are going to be on your test. Select all that apply. Okay, serum albumin levels may be decreased. Oh my gosh, why? What's albumin? Laura, talk. Protein, where's it going? In my urine. So I've already told you with glomerulopathies I can have anywhere from mild to massive protein loss in my urine. Okay? So mild proteinuria with this glomerulonephritis. The urinalysis, of course, hematuria. Yes, you know what color the urine is? Proteinuria, elevated specific gravity. What else did I tell you would be in there? Tells me glomerular damage. Red blood cells and red blood cell casts. Okay, good. May need to do throat or skin cultures. ASO titer, there it is in the second bullet. Antistreptolysin O indicates an ongoing infection. That is what I would treat. Is this infection in the kidney? No, it is where? It's in the body, in the bloodstream. The antigen-antibody complexes have formed. They get stuck in the glomerulus. They destroy the basement membrane or poke holes in it, along with the action of complement that causes red blood cells and causes red blood cell cast that tells me there's damage to the kidney with this type of nephritis. Other tests that I may need to perform to discover what the cause is, the antecedent cause: hepatitis B surface antigen and surface antibody, antinuclear antibody. What is that? Okay, fall. Indicates autoimmune response such as with SLE. I'm not going to poke a hole in that kidney, am I? I said Ms. Blackwell will talk with you about that in the fall. Okay? I'm not going to poke a hole in that kidney. Treatment. Goals. Number 1, to eliminate the antigen. If I stop the antigen from forming the antigen-antibody complexes, am I going to get better? Yes. So if their ASO titer is elevated, they need an antibiotic. Will that stop the formation of those antibody-antigen complexes? Yes. Number 2, preserve renal function. Number 3, prevent cardiac and cerebral complications of hypervolemia, and monitor electrolyte balances. The next bullet says I need to give diuretics and antihypertensives if the blood pressure is elevated. That makes sense to you? Okay. Control fluid intake, again, oliguria. So what's it going to be? Output, yesterday's output plus 500 to 600 milliliters. Good. Sodium and fluid restrictions depending on the volume state, hypertension, and what's the other factor? Edema. Good. Okay, dietary restriction of potassium if the potassium is elevated. They may need that ion exchange resin, and what's the drug of choice? Tell me, what are the other mechanisms for lowering your potassium besides dialysis? Insulin, calcium gluconate, sodium bicarbonate. All that's going to cause the potassium to do what? Go back into the cell. Is that a long-term fix or a short-term fix? Okay, good. Dialysis, short-term, hemodialysis. We're just going to have one of those temporary access devices, not that big old box thing on your arm, okay? Limited activity. Do you think this is going to be self-limiting on this patient? Their activity is going to be self-limiting? Why? What does that mean? I can only do what I feel like doing. Okay, so I might get up and wash a dish and then I have to lay back down. Okay, or I can put some clothes in the washing machine, but I got to go back lay down. And I don't have the energy to take them out and put in the dryer, much less to take them out of the dryer and fold them all up. Okay? So rest is important for this patient. Restrict potassium and protein intake to prevent what? Hyperkalemia and additional uremic manifestations of an elevated BUN and serum creatinine. You need to add that there. So if my patient has oliguria, are they going to have elevated BUN and serum creatinine automatically? Yes? The answer is yes. Okay? So if they have oliguria, you got elevated BUN and serum creatinine, not filtering. Treatment continues. Diet. I need what? High carbs for energy. Okay? To decrease metabolism of proteins. Protein restriction depends on the degree of azotemia. What's the definition of azotemia? Elevated BUN and serum creatinine and proteinuria. So what kind of protein should my patient be receiving? What should they be consuming? What's going to be best? Miss Goff is talking here. I need for you to hear her talking to you. What kind of proteins do I need to give my patient? Complete proteins, high biologic value. Yes? Give me an example of a complete protein that's going to almost have no residue when it's consumed. Yeah? And what? No, not animal meat. Okay. Macaroni and cheese, rice and beans. Okay, a Mexican diet's good, sort of. Okay. Lots of calories, though. Carbs, but that's okay. Carbs, calories, okay. But, again, do I need to be careful of spicy stuff? Okay. Antibiotics for up to 6 weeks. Oh, my gosh. How compliant is your patient going to be able to be? 6 weeks of antibiotics. Or until the ASO titer has returned to negligible amount. Does that make sense? Okay. All right, so dietary and activity restrictions are discontinued when edema and the hematuria is gone, the weight and blood pressure are stable, laboratory values, BUN and serum creatinine, potassium and sodium return to normal. So that's how I know that my patient has gotten better. So do I need to monitor these periodically to see if they are getting better? Yes, this is an answer on your test, important for you to remember and know this slide. Okay, I'm going to let you go take a break now, then we'll come back and talk about complications. Do you have any questions at this point? Oh my gosh, no, you just blew us away. We didn't read this, but we got to go back and read it, and we will, Miss Farn. Come back at 1/4 after.